pledge, and we're going to ask Dr. Hartbrock to lead us. Get out of the way, Doc. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you very much. So, it's great to be here. Committee will come to order. Thank you all for coming here and joining us today. I'm Congressman Neil Dunn. I represent Florida's 2nd Congressional District, and I'm honored to serve as the chairman of the Committee on Veterans Affairs Subcommittee on Health. As a veteran and a doctor, ensuring the VA is providing for those who have borne the battle is one of my deepest commitments in Washington. I'd like to begin by thanking Subcommittee Ranking Member, Congresswoman Julie Brownley, whose district we're sitting in, for her hard work on this subcommittee and her devotion to the betterment of our nation's veterans. I also thank you for giving me the opportunity to visit this beautiful part of the country. During today's hearing, we're going to take a closer look at the Department of Veterans Affairs long-term care and how it can be improved to best serve our aging veterans. The title of the hearing is VA Long-Term Care, What's Working, What's Not, and How Best to Serve Our Aging Veterans. The average age of the veteran population has increased over the last few years, and as has the number of veterans who qualify for VA-supported long-term care. That means the VA is now facing the largest demand for long-term care in its history. With this in mind, I have questions about how various VA long-term care programs work together, what the eligibility requirements are for these programs, and how the VA will manage this increasing demand, and what services veterans would like to have available to them as they age. I also want to hear from our witnesses about what is and is not working for the VA and the private long-term sector care providers here in Ventura County. Understanding the good, bad, and the ugly on a microscopic level can help us see and get the big picture and address some of the national long-term care issues. I was, as I'm sure many of you were, disturbed by recent articles in USA Today that allege poor quality care at the VA community living centers in different parts of the country. Though the VA has briefed the committee on the department's quality ratings, I remain concerned about the quality of the care being provided to veterans in this community and others in our living centers and in our other systems. The 3 closest community living centers to Ventura are in Sepulveda, Long Beach, and Los Angeles. Fortunately, all 3 of these facilities earn quality ratings of at least 4 stars, which is, I think, a credit to the good work being done by the staff there. I hope the VA will be able to speak to these ratings and what might be working well here in Southern California, and that might not be working as well at other facilities around the country, as well as how they plan to sustain and improve the quality of care provided to the aging veterans in this community. And I'm grateful to all of the witnesses for being with us this morning to discuss this important issue. With that, I now yield to the ranking member, Ms. Julie Brownley, for any opening statement that she may have.
Well, thank you, Dr. Dunn. And is my microphone on?
Oh,
There we go. Thank you, Dr. Dunn. And first and foremost, I want to thank you for traveling out west to be here in my district and to help us all to understand the concerns of veterans here in Ventura County and certainly across California and the nation. I appreciate the time you are taking out of what I know to be a very, very busy schedule to come and visit, and I hope you enjoy your time here in the most beautiful district in all of California. Your commitment to this subcommittee and the veterans we serve is undeniable, and your medical acumen on the committee has been proven to be extremely vital. And we appreciate your willingness to hold this hearing on VA's long-term care services here in Ventura County. So welcome to you and to everyone here today. As a housekeeping note, I just wanted to point out, while typically we don't have questions from the audience during Congressional committee hearings, but please know that I and my staff are here to help however we can and are very open to your ideas to improve any of these programs that we discussed today. Today's hearing will hopefully raise awareness, provide you with critical information, and if you have follow-up questions or issues to resolve, we will be here as a resource. During this Congress, the committee has held a number of hearings on the Caregiver Support Program, and these hearings led us to realize that VA long-term care services have somewhat flown under Congress's radar for far too long. Overall, Americans are living longer, so we must be prepared for how to care for them. And this is especially important at the VA, as more than 12 million veterans across the country are over age 65. I was proud to vote to expand the caregiver program as part of the Mission Act. However, this program will not meet all of the needs of our aging veteran population. This hearing is meant to be the first step in ensuring VA's long-term care services are designed and implemented in a manner that ensures veterans receive the care they need in a manner that reflects their preference. Not only will this promote the quality of care veterans receive, but it will allow VA to better allocate its resources. Outside of VA, we have seen a significant shift from institutional care, such as nursing homes, to non-institutional care, such as medical foster homes. However, as in the case of medical foster homes, many of these new innovative types of non-institutional care require the veteran to pay, as the VA lacks the ability and resources to do so. Just last week, the House of Representatives passed the Long-Term Care Veterans Choice Act that allows VA to pay for up to 900 veterans per day to access medical foster homes. Now we must look towards other programs such as home health aides and assisted living facilities, among many others that VA offers to aging veterans and those with disabilities. We must ask, are there gaps in eligibility? Are the programs affordable for veterans? Does VA have the resources it needs to ensure veterans are aware of and able to access the programs that best fit their long-term care needs? In preparing for this hearing, I was impressed at the number of different programs within VA that are meant to support its aging and disabled veterans. However, I am unsure that both VA employees and veterans are fully aware of these programs, their eligibility requirements, or how they interact with programs outside of the VA. By turning a congressional eye towards VA's long-term care services, I am hopeful that we can bring more attention to these programs, the areas in which they excel, and the areas in which they may need a little or perhaps a lot of help. Obviously, the best way to do this is to speak with veterans, veteran service organization, VA experts, and my colleagues on the committee. Today's hearing is an effort to establish the lines of communication between each of these stakeholders so that as we move forward, we are fully informed. I appreciate each of today's witnesses for their willingness to engage in this conversation and to spread more light on these programs and the veterans they serve. I look forward to our discussion today, and Mr. Chairman, I yield back.
Thank you very much, Representative Brownley. Before I introduce our witnesses, I want to remind everyone that today's hearing is a formal congressional hearing, just as if we were holding it on the Hill. It's brought it here to you. So we have a routine. What we're going to have is one panel of witnesses, and only those invited to testify will be permitted to speak. Each panelist will have 5 minutes for their opening remarks, and I respectfully ask that our panelists keep an eye on the timers in front of you there, which these are, we brought from Washington. These are authentic. I have to live under this pressure as well as you. We've had some very thoughtful submissions for the record for this hearing from local experts in long-term care, such as Dr. Bernard Salick of Salick Comprehensive Diabetes Centers, and Julian Manila, who is also with CalVet. I encourage those watching this hearing to read these submissions, which are included as part of the record for this hearing, and will be available online at our committee's website, which is www.veterans.house.gov. There will be an opportunity after the hearing for those of you in the audience, come up and speak with myself, Representative Brownley, our staff members, if you have questions, comments, suggestions, if you need further assistance. Joining us this morning on our first and only panel is Katie Krull, Acting Executive Director for the Oxnard Family Circle Adult Day Healthcare. Mr. Mike McManus, County Ventura Veterans Service Officer, the Veterans Service Collaborative. Mr. Thomas Martin, Assistant Secretary, Homes Division for California Department of Veterans Affairs. And Dr. Teresa Boyd, the Acting Assistant Deputy Undersecretary for Health for Clinical Operations and Management within the Department of Veterans Affairs, who is accompanied by Dr. Hartwell, Chief of Staff for the VA Los Angeles Greater Los Angeles Healthcare System. So welcome all of you here. Thank you so much for being here. And Ms. Krull, we're going to begin with you. You're recognized for 5 minutes.
Oxnard Family Circle Adult Health Care is a medical model day program that provides care for veterans in our community. The veterans who receive care are at risk of skilled nursing placement if they do not receive services at the center. They are frail, elderly individuals who require intervention from registered nurses, rehabilitative services, and assistance with personal care needs, including toileting, feeding, and bathing. We provide transportation for veterans from their homes to the center, meals, stimulating daily activities, social work case management services, and psychological counseling, such services, and podiatry care. The center also has specialized memory care unit that we developed in conjunction with Alzheimer's Association. Many of the spouses or other family members of our veterans are overwhelmed with the day-to-day responsibility of caring for the veteran. We find that the caregivers are at risk of experiencing a decline in their physical and mental health condition. Our program is the resource for vital rescue care for many families, as it offers day-long extended services for 5 days per week. Oxnard Family Circle provides care to veterans who have served in World War II, Korea, Vietnam, Iraq war periods. Essential benefits for veterans in our program are camaraderie, a sense of social belonging, and connection to a group that is unique to their shared military experience. We develop an individualized treatment plan for each veteran that focuses on specific medical, dietary, and psychiatric needs of that person. Specialized programming that is provided includes refined family programs, outings that facilitate integration into the community, psychological groups, one-on-one counseling services, music and memory activities, art therapy, support groups for family members, educational events in conjunction with Disabled American Veterans, Alzheimer's Association, Public Health, and Ventura County Area Agency of Aging. Our setting allows veterans to function with a sense of dignity. In home setting, they often feel diminished, and their loved ones assist them with basic activities for daily living, including toileting, bathing, having assistance with transfers and walking. Many of our veterans are uncomfortable and resistant to family members providing this level of assistance. Veterans and their families benefit from the personal care assistance that is provided by Oxnard Family Circle's personal staff, professional staff. Oxnard Family Circle works closely with the Department of Veteran Affairs to coordinate the care needs of veterans. Referrals for adult health care services may be received from the local VA outpatient clinic. Many veterans reside in our community who may not be connected to the VA healthcare system. Our staff educates veterans to the types of benefits that they may receive and assist them with enrolling in the healthcare system. We also refer veterans and families to the Ventura County Veterans Service Office for assistance with financial benefits. We maintain close communication with the veterans physician and VA social workers during the time the veterans are enrolled in our program. When the veterans' care needs increase so that adult health care services are no longer appropriate, veterans may be referred to the VA Community Nursing Home Program or VA Hospice Service. Even attendance may be applied for to pay for care in the veterans' home setting or assisted living facility. All veterans who are VA health care eligible may be appropriate for adult health care care services as long as the veteran has been determined to have the following clinical conditions. First, the 3 or more activities of daily living dependencies. Or second, significant cognitive impairment. Or third, require community adult day health care services as child care and community hospice services. Or fourth, 2 activities of daily living dependencies and 2 or more of the following conditions. Veteran has dependency in 3 or more instrumental activities of daily living. Has been recently discharged from a nursing facility or upcoming nursing home discharge plan contingent on community-based care services. The veteran at 75 years old or older can have high use of medical services defined in 3 or more hospitalization in the past year, and for utilization of patient clinics, emergency evaluation units 12 or more times in the past year. Veteran has been diagnosed with depression and lives alone in the community. We practically appreciate people's support and advocacy that can be provided by Congresswomen Brownley office. Thank you for allowing me.
Thank you very much, Ms. Kroll, and thank you for thoughtfully including the admissions criteria for your program. That's helpful for those of us coming into the situation. Mr. McManus, you're recognized for 5 minutes.
Former Chairman Dunn, Ranking Member Brownley, thank you for the opportunity to provide some information to the committee regarding long-term care options for Southern California veterans. My name is Mike McManus. I'm the County of Ventura's Veteran Service Officer. My staff and I connect fellow veterans, their dependents, and survivors with federal and state benefits and local resources. One of our primary responsibilities is connecting veterans with VA disability compensation for such things as post-traumatic stress, traumatic brain injury, and for conditions resulting from physical and psychological injury while in the military. We also assist veterans to enroll in VA healthcare and refer them to local and regional care resources. My office has 5 accredited individuals who interview veterans, file their corporate benefit claim, and advocate on their behalf and make referrals to service providers. We also have support staff that enable us to meet our client needs. The Veteran Services Office has conducted a variety of outreach activities to inform the veteran community about their benefits, including VA healthcare. The office currently operates out of the main office and 10 field offices. We have a variety of partners through the Veteran Collaborative of Ventura County that also helps us reach veterans. And just as an example, in fiscal year 12-13, my office saw 3,572 people. However, last fiscal year, the one that just ended in June, we saw 6,764 people. So we're encountering a lot of veterans, briefing them on the benefits, connecting them where we can. However, there's obviously a lot of work that can be done because there's 40,000 veterans in the county. I myself am a retired Air Force Senior Master Sergeant, spent nearly 20 years, or spent just over 20 years, ended up as a first sergeant with one deployment for Iraqi freedom. And as a first sergeant, I was involved with briefing the commander on anything that had to do with the enlisted members of the unit, including physical and mental health. I've been the Veteran Service Office to Ventura County since January of 2010, and it's an honor to continue to serve our veterans. So there are a variety of veterans or benefits that are eligible to veterans when it comes to long-term care. Usually the veteran would start by seeing their primary care provider or social worker at the Oxnard community-based outpatient clinic. As I alluded to earlier, Ventura County has over 40,000 veterans, thousands more National Guard, Air National Guard, and Reserve personnel who may, over time, be eligible for VA long-term care. Approximately 22,000 Ventura County veterans served in World War II, Korea, and Vietnam, and their age ranges from 65 on up. In addition to the typical ailments of aging, over 4,100 of these veterans also have chronic injuries from military service. Now, those are individuals that have filed disability compensation claims, so you can anticipate that there's an unmet need there because many veterans have not yet filed those claims. In essence, we have tens of thousands of veterans in Ventura County, and many of those there's a large unmet need in the community due to misperceptions on the part of veterans and lack of information from the VA. My staff and I have spoken with countless veterans who thought that Medicare, TRICARE, or the VA would provide for their long-term care needs. They aren't aware that Medicare provides very little in terms of long-term care. TRICARE even less, and the VA only if the veteran is eligible. Typically 70% service-connected or higher, and of course based on clinical need. As outreach to the military veteran community increases from organizations such as my office and those that are members of the Veteran Collaborative in Ventura County, the number of veterans seeking services increases, and we need to be able to better educate them on their realistic options. In addition to veteran misperceptions, there's lack of information provided to veterans regarding VA long-term care. Now, in Ventura County, I'm just going to run down through some of the options that I'm aware of and that my office helps to connect veterans to. Of course, we'll learn more about the VA nursing home on the Greater LA Med Center campus. The VA also has 3 community living centers, or what we used to refer to as nursing homes, in Ventura County. Coastal View Healthcare Center and Shoreline Care Center is in Oxnard, and I recently learned of Maywood Acres also in Oxnard. Typically, a vet has to be 70% service connected or higher, and I bring this up is because for those individuals that are service connected in Ventura County, only 4% are 70% or above. Now, of course, it also means that, or there's an option for veterans that are enrolled in VA healthcare that require hospice in a nursing home could also be eligible for VA nursing home care. But I just want to be able to illustrate that 4% are 70% or higher. So what about the rest of our veterans? So in some cases, maybe they turn to Medi-Cal. You know, there's also home health aides, which are very important.
Go ahead, finish real quickly if you can.
All right. I was already self-editing there, but all right. So veterans primary care provider, they are usually where this starts, especially when it comes to homemaker and home health aid care programs, which basically the VA contracts with someone to come into the veteran's home, provide care for the veteran and respite for the family care member. Katie already touched on Oxnard Family Circle, which is a vital service to the county. There are several hospice providers that also play a part in this long-term care. Livingston Memorial Visiting Nurse Association and VITAS are, a couple in the county that have routinely received positive comments. And I also just want to briefly, everything we've talked about is on the VHA or the Veterans Health Administration side, but on the benefit side, there's also this opportunity.
Thank you, Mr. McManus. I do appreciate the inclusion of some of your organizational structure and the quantification of some parts of your budget. In general, more quantification of these things is helpful to us in Washington, so that quantification is good going forward. I will tell you that in Washington, you'd have been cut off like a minute.
Well, I appreciate your indulgence.
You are in such a good role. Mr. Martin, you're now recognized for 5 minutes.
I'll do my best. Thank you for the opportunity to be here today to facilitate this conversation on long-term care. Projecting future healthcare needs is a top priority for CalVet at the moment. And so we certainly work with many efforts. My apologies. Projecting future healthcare needs is a top priority for CalVet at the moment. So this is a very good time for us, and I think there's a good opportunity for more communication and collaboration between the state and federal government and also private providers. So first, let me start with some background information on our program. CalVet operates 8 veterans homes located throughout the states that each offers a range of care options. So independent living, assisted living, skilled nursing, and skilled nursing secure memory care units. The homes vary in size from 60 to 900 beds. And we're very proud to say that all of our homes, our Medicare rated homes, are at 4 or 5 stars. In total, we care for about 2,400 veterans and spouses. As Congresswoman Brownley knows, we have the Ventura Veterans Home nearby. It's a state-of-the-art 60-bed assisted living facility, and it's a personal favorite of mine, but don't tell the other homes. So, to be eligible for admission, applicants need to be former active duty military personnel. They must be aged or disabled. They must be California residents, and they must qualify for long-term care from the VA. And we also admit spouses for certain circumstances for joint admission. We also have priority admission for Medal of Honor recipients, former prisoners of war, homeless veterans, and veterans with high service-connected disabilities. So the veterans' homes are closely connected to the VA in 4 primary areas. The VA annually certifies and surveys our veterans' homes to ensure residents receive quality health care in a safe living environment. Second, the VA also pays a per diem for all of our qualified veterans. It ranges from give or take $50 to $500 or more, depending on location, the service connected disability rating, and the care needs of the veteran. Third, the VA funds up to 65% of construction costs for approved projects, so to include the Ventura home nearby. And finally, of course, many of our residents continue to receive specialty services and other forms of services from the VA. So I understand that one of the goals of this hearing is to discuss strategic planning for veterans' long-term care, which, as I said, this fits quite well with what we're working at the moment. We know there are clear generational differences between each generation of veterans. Our residents right now are World War II vets, Korean War veterans, and Vietnam-era veterans. And with what we've seen now, there's clear differences in how late they wait to apply for long-term care, which means they tend to come in older and with more significant healthcare issues. There's differences in the level of the type of community environment they want to be surrounded in, the level of privacy they want, the type of activities they're interested in. So at the moment, CalVet is undertaking a census statewide needs assessment to identify this generational change, both in terms of the demands of the generation, and also in terms of the level of support that's going to be needed for them. Our intention is to take this data and to translate it into really what we should look like in the future. And obviously this means we need a good sense of what resources are available beyond just the veterans home and how we connect into that. It's pretty clear that there's going to be a high demand for skilled nursing on into the future. There's going to be a sustained need for secure memory care units for dementia patients. And we also expect more demand for mental and behavioral health programming that focuses on post-traumatic stress, substance abuse, and other conditions that frankly don't fit the model of a long-term care patient in the classical sense. And finally, most importantly, we hope to better understand how the VA, veterans homes, nonprofit organizations, and private facilities are or aren't equipped to meet these needs, to meet these challenges, and how we can best bridge the gap to ensure that veterans get the full spectrum of care that they've earned. So with that said, I think the most important thing I can say is that there really is no single provider that can offer everything for every veteran. If there's one thing to take away from that, I think that's the most important thing. So we certainly look forward to the VA's leadership in outlining where they expect providers to be. And again, I'd like to thank you for this opportunity to be here today for setting this up for us.
Well, thank you for being here. Thank you for your testimony. And you mentioned taking the census, where I took note of you saying that. You said you will have some data, and data is what we run on, so please include Representative Brownley and our committee in that report, if you would, please.
Absolutely.
And Dr. Boyd, you're now recognized for 5 minutes.
Good morning, Chairman Dunn, Ranking Member Brownley, and members of the subcommittee. I appreciate this opportunity to discuss VA long-term care for veterans and their choices for care as they age or face catastrophic injuries or illnesses. I'm accompanied today by Dr. Scotty Hartram, Greater Los Angeles Healthcare System Chief of Staff. VA's Office of Geriatrics and Extended Care, or GEC, is committed to optimizing the health and well-being of veterans with multiple chronic conditions, life-limiting illness, frailty, or disability associated with chronic disease, aging, or injury. GEC's programs maximize each veteran's functional independence and lessens the burden of disability on veterans, their families, and caregivers. As in the case of the 77-year-old World War II veteran, airplane mechanic, and retired country physician, diagnosed with debilitating Parkinson's, whose care is delivered by occasional admissions to a community nursing home, assisted in the home by a homemaker home health aide, and the support of his spouse with respite care. Or the 69-year-old Vietnam veteran, West Point grad, with devastating diagnosis of metastatic lung cancer, who is able to spend his final days in his home under hospice care with family. And finally, the 32-year-old Navy veteran with a lifelong medical diagnosis who no doubt will rely heavily on our VA system of care as he ages with a chronic disease. As veterans age, approximately 80% will develop that need for long-term services and supports. The aging of the veteran population has been more rapid and represents a greater proportion of the VA patient population than observed in other healthcare systems. GEC's programs include a broad range of long-term services and supports, one of which is home and community-based services. This program supports independence by allowing the veteran to remain in his or her own home for as long as possible by using one or more of these services, including adult day health care, home-based primary care, homemaker home health aid, palliative and hospice care, respite care, skilled health home care, telehealth, and veteran-directed care. In addition to improving care for veterans, home and community-based services reduces costs for the department. VA financial obligations for nursing home care in fiscal year 2017 reached $5.7 billion. The number of veterans with service-connected disabilities rated 70% or more, for whom VA is required to pay for nursing home care when indicated, is projected to double from 500,000 to 1 million veterans between 2014 and 2024. Therefore, if nursing home utilization continues at the current rate among veteran enrollees, without even considering inflation, the cost to VA for providing nursing home care for enrolled veterans can conservatively be estimated to reach more than $10 billion within the next decade. There's an urgent need to accelerate the increase in the availability of these services, since most veterans prefer to receive care at home, and VA can improve quality at a lower cost by providing care in these settings. States have found that through their Medicaid programs, they have been able to reduce costly nursing home care by balancing their expenditures for long-term services and supports between institutional and home and community-based settings. VA's spectrum of home and community-based services include adult day health care. This is one of the strongest sources of caregiver support and respite, and is greatly valued by veterans and their family caregivers who rely on this program to help the veteran to remain at home as long as possible. While VA does not have sufficient data regarding the cost benefit of this program, the Medicare program for all-inclusive care of the elderly is based largely on this program and has demonstrated strong success in helping frail, older adults at highest risk for nursing home placement to instead remain living at home. Nursing homes are settings in which skilled nursing care is available 24 hours a day. All veterans receiving nursing home care through VA must have a clinical need, as mentioned, for that level of care. VA strives to use nursing home care when a veteran's health care needs cannot be safely met in their home. VA also maintains strong working relationships with the states in the oversight and payment of veterans care through state veterans homes. There are currently 156 state veterans homes across all 50 states, including one here in Ventura, California. We recognize and appreciate the commitment of all of our partners here today. VA's various long-term care programs provide a continuum of services for older veterans designed to meet the needs as they change over time. Together, they have significantly improved the care, well-being, and dignity of our veterans, including that 77-year-old World War II veteran, that was my father. The 69-year-old Vietnam veteran, he was my eldest brother. And the 32-year-old Navy veteran, he is my stepson. The gains in the long-term care provision of care would not have been possible without consistent congressional commitment in the form of both attention and financial resources. Your continued support is essential into providing high-quality care for our veterans and their families, present and future. Mr. Chairman, this concludes my testimony. My colleague and I are prepared to answer any questions. Thank you.
Thank you very much, Dr. Boyd. And we will start the questioning now. I want to comment that your testimony was very nationally based, which is, of course, what you do. We're here in Ventura County. We're hoping to get a kind of a granular view of Ventura County, or at least maybe bring it down to the VISN 22 level. If you in your position cannot drill down to a specific visit or a county, we can't do it either. So we're hoping we can find out how things work on a county level. I will now yield myself 5 minutes. You have to restart that clock. That was just me editorializing. So I will now yield myself 5 minutes for some questions. Let me start off, if I may, with you, Dr. Boyd. We've made, Mr. Martin made a great comment about a census and data gathering, looking at the shortcomings and what do we need in the way of data, what are we going to need in the future to treat our veterans. Is this being done throughout all the VISNs or all the states, and if not, should it be?
So that is a good question. We are currently at the national level looking at this because, as I mentioned in the testimony and also in the written testimony, we are very concerned about this that's coming upon us now. We can drill down to individual VISNs and regions by looking at our forecasting models as well. So you can be assured that this is being done. What we do with that and how we parse it out to the different programs is yet to be decided, but we are definitely very concerned and are on top of that.
Great. So while we're talking, your written statement referred to 20 centers of excellence in the VA. What are these centers of excellence? What do they do? What's their role?
Okay. So the 20 centers of excellence actually help us. We could have a whole hearing on this, but in a nutshell, they really help us with our innovations and what we can do moving forward. I do believe that we have a Greg here within VISN 22, and Dr. Scotty Hartram can do a little bit of writing about that site. But in essence, they help us with looking at the world of the possible and how we can implement changes in actual clinical practice in the field. So with your permission, I'd like Dr. Hartram to discuss a very good program here within the GLA area.
Yeah, that may be right. A conversation for another time. I would have, somebody mentioned, I think it was you, Mr. Martin, or maybe Mr. McManus. McManus was the hospice care. And it's a subject near and dear to my heart. I think hospice care is underutilized. I think it's an important part of medical care. And I think it's a very compassionate and helpful thing to do. Surely Medicare reimburses whatever program is providing the hospice, whether it's a VITAS, Oxnard, or a VA program. Does the VA file against Medicare insurance for the hospice care that they provide to veterans?
It's my understanding.
No. Is that your understanding, Mr. Martin Calvex? You know that?
Right, I'm not aware of.
Why wouldn't they? Does that make sense? I mean,
So hospice care is available to any enrolled veteran.
it's also available to any Medicare patient. Mistake. I got out over my skis there. So on the subject of telehealth, I was interviewing a doctor in another city, another visit, and he said that he's by far and away the most efficient that he gets is in the telehealth. He was saying he sees 30 to 35 patients a day in telehealth versus 12 to 14 if he's in clinic. First of all, that's a very low number for a clinic, I happen to know. But also, maybe we should do more telehealth, and I'm not sure we should address that. Maybe Dr. Armstrong.
Luckily, telehealth has come a long ways, and one thing that we're finding out is how to, because as you imagine, telehealth is only as strong as how you're able to get the communication to both sides. And now we're trying, currently we've had a lot of success with having, especially with specialties that could be at West Los Angeles, that could then have care out into our smaller community clinics. But now we're also, like with mental health, they're developing a way to send a link to the veteran by email, and they can actually use that as a way to do telemental health to their home. So we're
He was actually Skyping, or the version
Yes.
of Skyping that you have in the VA.
Yes, sir. So we're evolving with telehealth. I think actually the easiest we make it for the patient, the veteran in their home, the more acceptable and accessible it will be. So I think we've already overcome the having to have someone go to their home, set up the modem, all this type of technological challenge. So now where you can send them a link that they click on and they go through email, you can imagine. So I think the telehealth is becoming a much more robust, and as you said, being able to provide mental health in their home and other services is going to be key.
And let me say that the VA is in a unique position to develop this capability because we don't rely on the state boards, the state medical examiners that we're in. So with that, I'm going to yield to Representative Brown.
Thank you, Mr. Chairman. Dr. Boyd, I wanted to drill down a little bit with you on this issue of institutional versus home or community-based services or care. And certainly over the past couple of decades, federal financing and delivery of long-term care, particularly for the largest federal payer of long-term services, which is Medicaid, we say Medi-Cal here in California, has shifted toward the provision of care in home and community-based settings rather than institutional care. And I think I read somewhere in the briefings prior to this meeting that Medicaid, Medi-Cal is roughly around 50% and the VA is roughly around 31%. So, if you could speak a little bit to, what is the right proportion that you see, across the nation in terms of where the VA is, and if we're not there yet, what are we doing to get there?
Thank you. Thank you. Great question. And you're absolutely right. We can learn a lot from our state partners and in various states as well. We do need, as a VA, we do need to move upstream and not wait for institutional care, and we're learning that. There are many programs, as we mentioned, that are not just in the community. We have some programs in the home and community-based settings that are dual-based, whether the VA may provide some of it, but we buy some and purchase them from our community partners. But we need to do better. We need to focus on more of that. And whether that means reaching out and developing those partnerships, either through contracts, and with some of the new legislation with regards as choice fades away, we'll have contract negotiations as well. So that, in our mind, is where we need to be, moving it back to the left, so our veterans can stay safely at home with caregivers, or supplementing those needs, whether it be the adult day health care during the day, and in the evenings or the weekends they have homemaker home health aid and respite care. But you're absolutely right. We have lessons learned, and we are moving in that direction for so to age gracefully and safely at home.
Well, thank you for that. I know in Washington we talk a lot about this, and we spent a lot of time back in Washington talking about the caregiver program, and the committee has worked towards expanding the caregiver program to post 9/11 veterans, where it was previously just pre-9/11 veterans. But I think we all agree that in the long term, it's a win-win situation because veterans prefer to stay in their home generally, and I believe also that many of these in-home services or community-based services, at the end of the day, is less expensive in the long run than institutionalized care is. And we know this bubble is coming through. We call it the gray tsunami coming through, and I think we've just got to make sure that we have clear and articulate plans on how we're going to address that. So as our aging community ages, no one is falling through the cracks. I wanted to also ask, I think there was, perhaps some confusion, and certainly in terms of reading the materials prior to the meeting, I was also getting a little confused as well. So, and this is really about trying to understand, we have, and you listed most of them, I think, Dr. Boyd, in your testimony, of all of these long-term care options. And some, as Mr. McManus mentioned, require a veteran to be 70% disabled or higher in order to be recipients of some of these services. But there are a lot of these programs that are based on physician decision, clinical needs. So if you could kind of break down for me, and I think that's important for certainly our veterans here in Ventura County to understand what the programs are, and certainly Mr. McManus, who spends his days, that's all he does, is help and assist veterans in our community, to understand where, I think that there are less programs that require the 70% disability requirement than there are just simply clinical decisions. So if you could break that down a little bit.
Yes, I will, thank you. And I did make note of that when Mr. McManus was giving his oral testimony. It dawned on me, Congresswoman Brownley, that we need to do a better job of getting that information out. And I specifically wrote that down. What are we doing? How can we be better at that? And being a push instead of a pull organization with regards to information. But you're absolutely right. And please, Dr. Hawtrump, let me know if I stumble here, but really the 70% service-connected or greater really falls into we are to provide for those veterans in our CLCs or provide nursing home care. Beyond that, most of the other and the State Veterans Home has their eligibility as well. But beyond that, the other long-term services and supports, you are an enrolled veteran, you are eligible for those if you meet the clinical need. And many times that's in a conversation not only with the veteran, but with the family, with their caregiver, with their support system as well to get the complete picture. And early on even, although it doesn't go directly to the eligibility part, it goes to the veterans' preferences. So we start very early in our partnership with our veterans as that relationship in discussing goals of care. So where do they want to be? What is most important to them? And so then that's where we fit around those services that they are eligible for as enrolled veterans. So I hope that helps a little bit.
Yeah, thank you. I've exceeded my time. Mr. McManus and I are both in trouble. But I yield back.
Yeah, a stern note will follow. So that actually was exactly where my first question was going to go. I think that you mentioned that it's a hard time for people to know what they're eligible for. Well, even this committee, members of this committee care about this. You know, it's hard for us to understand what's available nationally, let alone the granular level. Each county, each visit, each locality may have certain things available that aren't available anywhere else. And so if we don't know how to use it, if our staff doesn't know how to use it, how in the world are the veterans going to know how to use it? I have actually seen some early programs that are, again, coming from outside the VA, not inside, that are trying to organize that approach based on the location, the geolocation of the veteran. And I'm going to be bringing more of that into the committee as we go forward back in Washington. But that would be a great thing to have a flow sheet. And I guess I should say start with a national flow sheet and then fill in the location, the geolocation you're in, and what additional support is available for veterans through that. So that's a commentary that's very, very, very important. We should meet on back in Washington. Dr. Boyd, in your testimony you said 80% of veterans will develop a need for long-term service. What percentage of those veterans meet the criteria for VA-paid nursing home care nationally? So that's a national question. Should be in your wheelhouse.
So the question is with regard...
So if 80% of all veterans are going to need long-term services as they age, what percentage meet the VA nursing home 70% disabled criteria or the necessary critically ill criteria?
I don't have that national number for you, but I will get it for you.
Well, it's an important thing for us,
yes, it is.
We're talking about, what do we blow through about $100 billion a year, right? So we need to know
absolutely
what that comes up at. Also, let me address, if I can, the foster homes. Representative Brownley talked about that. The medical foster homes to us, to the people who've come to us in Washington and testified to us, seem to be very popular options, and they're very cost effective. So what are our plans for expanding that program? Dr. Boyd, or Dr. or whoever, I think it's Dr. Boyd.
Yeah, sorry, make you see that was on still. So yes, the medical foster home is actually it's a very good program for many of our veterans. It's not for everyone. We do have about 1,000 enrolled
which is a pretty small number across.
It is a small number. It is a very small number. There are over 700 medical foster homes, caregiver sites. in most, involving most states. Although we do know that this is expanding in many others. The average cost is about $2,400 per month, and that's on the veteran. What we do know is a quarter.
There's no hope for the veterans' benefits if they qualify for certain benefits, that money couldn't be paid to the foster home?
But if that's an authority that would be.
We just passed that authority.
Okay.
Just
So,
this.
there you go.
The president
There you
hasn't signed
go.
it yet.
Oh.
We did pass it
It's
out.
coming.
Committee.
Get ready.
Yeah.
I'll be glad to talk about it next time. Okay.
Okay, so I'm a little ahead here again, but I think that's a popular thing. The veterans are telling us they like it. It saves us a bunch of money. It saves the taxpayer. I mean, I think we ought to be able to lean into this as soon as we get the signature on the final document. Mr. McManus, one of your primary roles is to assist veterans enrolling in the healthcare system. Can you walk us through that enrollment?
Sure. So basically, it's going to start with discussing, reviewing their DD-214 or their discharge document to see if they are indeed, have some basic eligibility, and they've actually got that form. And then, of course, there's a 1010 EZ, which is the application form used by the VA. They then take both their DD-214 and that application to the Oxnard CBOC, and they talk with either Dan or Scott, and they review their DD-214 to make sure they've got the qualifying length of service, or maybe a campaign medal if they're a recent Iraq or Afghan vet just discharged from service, and they will enroll them. And then there's a vesting physical that will come where the veteran provides blood, urine, and then they eventually meet with their primary care doctor to review those results, as well as whatever might be on the veteran's mind. The veteran could also go online and enroll online, and then ultimately be contacted by the Oxnard CBOC to be scheduled for that vesting appointment.
So I know that the online, and I'll end this very quickly. I know that the online system has gotten better over the last few years, but I tried to use it to just enroll just to get a card 4 years ago. I'm still waiting. I yield to Representative Brownley.
Thank you, Mr. Chairman. So, we have, and Dr. Boyd reviewed many of the programs within her testimony in terms of services, non-institutional care services and institutional long-term care services. And, it goes from, those are the non-institutional ones. Institutionalized ones are community living centers, which I understand we have one both in County as a contracted out facility. So I even wonder how well the physicians within the CBOC are trained to understand exactly what programs are available to them. So while we're here in Ventura County, I just want to get a firm agreement from you, Dr. Boyd, that we can bring some VA professionals into the county so that we can have a roundtable discussion or whatever to inform our veterans, to inform our physicians, and certainly inform Mr. McManus and the county, who are tremendous partners in all of this. So
Absolutely.
very good, very good. The other thing I just wanted to briefly hit on in terms of institutional care, it is stated by the VA that institutional care, veterans can receive institutional care if they are non-service connected veterans, if there is room, the caveat of sort of if there is room. So what percentage are we talking about in terms of veterans who are in nursing homes? The VA is, I presume, is paying for it, but are non-service connected.
So I do not know the national numbers on that, but I can tell you this, that the veterans that are not 70% or greater service connected are the majority of veterans. Okay, so I don't know the national numbers. I will get that to you when I get back with you about the other promise for the eligible, and about the resources available. So if there's a clinical need and there is a bed within a VA CLC, we absolutely will bring that veteran in. If there's not, but there's still a clinical need and there's no other option, a safe option for that veteran, then we do look to the community. Although there is a, I think, 180-day cap on the VA paying for that, but in that interim, they have tremendous coordination and case and care management with the family and the veteran to see what's the next step. And they don't do it on day 180, they do it on day 1 to help with that transition. So.
Very good. So just in terms of, we're using CLC for the audience. That is a community living center, which is like a nursing home, but they are associated with medical centers across the country. So if you're in the hospital in LA or getting care from Sepulveda, this is, you sort of go there for rehabilitation and other kinds of things. It's not necessarily a very long-term, everybody that's there, it's assuming that they're gonna recover and go home, in essence. But the question is, do we have the appropriate number of community living center beds across the country? I certainly, again, back in Washington, we talk about nimbleness and following where the demands are across the country, and Ventura County is a perfect example, large demand. We've increased our CBOC, but are we going to increase services here in Ventura County like community living centers and like some of these other services that we've been talking about?
So with regards to overall, and I apologize for not mentioning what CLCs meant earlier to the audience here, to the group here. With regards to the actual number, I don't foresee in the near future building more community living centers. What we need to do though is look at right-sizing our veterans that we have that need the institutional care. And again, use the opportunities to work with our partners in the community and move that upstream.
But do we have wait times for people to get into these beds?
To my knowledge, we do not have wait times for the combination of community living centers and CLCs and the nursing homes. If we have a 70% or greater service-connected veteran who needs care, and we do not have an available bed, say it's going to be available in 10 days or 15 days or whatever, we will take care of that veteran in a community, in a contract nursing home that the patient and the family agree to. So we will take care of that.
Thank you, and I yield back.
So that last question that Representative Brownley asked, about the wait times, is there a long wait time, significant wait time to get in these beds? I'm going to direct that question to Mr. Martin. I think he might have a better feeling for it locally.
I couldn't speak to obviously their CLC facilities. I can't speak to our veterans homes. So we do have wait times for most levels of care.
Roughly.
In veterans homes. It varies depending on location and the level of care. So in Ventura,
roughly average days.
So in Ventura, it's probably a matter of a handful of months at the smaller facility here. But we do something similar to them. We can refer them to other facilities that can take them pretty quickly, depending on the level of care.
Did I hear you say months?
Correct. Yes.
So.
This is a very popular one, veterans.
It's very popular.
This one particularly is very popular, but it only has 60 beds.
Well, so that actually gets into another question I had, and I was intending to give it to Mr. McManus, but maybe Mr. Martin, you could come in too. We talked about the waiting list. Is there so there is very much a preference for certain ones. Is there a preference for different programs?
Oh, certainly, yes. So as I mentioned in my own testimony, there's certainly a lot more demand for skilled nursing and for the highest levels of care. And in particular,
memory units?
Yes, in particular memory care.
How are you set up for memory units?
I'm sorry?
Are you short?
We are. There is a lot of demand for memory care units, and it's actually a relatively new offering that we've only started in the last handful of years.
I thought at Oxnard, I saw where you have an outpatient memory unit. Can you explain to me how that works?
We have a special area designated for those who have compromised memory. This area is secure, and the people who are there receive special treatment. They have higher level of nursing care, they have higher level of personal care. Those people require one-on-one feeding. Those people require maybe 3-to-1 toiletry just because it's complicated for those.
So this would be for like 10 to 12 hours a day?
It would be, depends, if family needs it to be the whole day, it will be like as early as 7 a.m. and as late as through the day till 5 p.m. It could be possible that, yes.
So, and then when the family picks them up, they're
We provide
back on
transportation.
the families.
That's correct. We provide
Memory
transportation. Though, the best part of this unit is that it's complete nursing care. Whatever medications have to be administered, they are administered. Whatever other nursing care or rehab care is needed is done. People are safe, in controlled, safe environment. There are special activities to stimulate them to get their memory, maybe not returned, but at least they are not anxious, they are not pacing, they have controlled environment, and families really appreciating it a lot because during the day, they take care of themselves, go to their own doctor appointments, go to work, and that's a huge relief because the burden of caregiving is the biggest burden for families.
So let me turn to Dr. Harcroft again. How much does your, you take care of the whole visit or just the GLA?
Just the GLA.
Okay, how much does GLA spend on long-term care?
Long-term care, specifically.
Total, all up.
Oh, okay, for all of our NIC programs, it was, with obligations in FY17 were approximately 40 million. The contract in the community nursing homes was approximately 29 million of that.
Thank you. That's quantification. That's numbers that help us. I'm going to go back one more to Dr. Board. I think veteran-directed care, a certain niche of care that has been funded. You know, where the veteran, you budget the veteran, and they sort of contract their own care. What do you think of the program? I think it's popular. It doesn't seem to be widely available. Talk to me.
Yes, on veterans-directed care, we have 62 VA programs.
Microphone.
In 18 visits.
You're not on. There you go.
Yes, it is fairly popular in some locales. We do have programs in 18 of our visits, or all of our visits. There are 62 VA programs, 36 states, but only a little over 2,200 veterans are utilizing the program. Again, as Ms. Krull had mentioned, this is a program where they do need assistance in more than 3 ADLs, and there's some other eligibility requirements. But this is a unique partnership that VHA has with local aging and disability networks within communities. So we do rely on that. It may very well be that the VHA, a VA medical center, wants to have the program, but they really need to work with that local agency, and sometimes there are some administrative technical things that we do try to work out. And the program's not for every veteran. Someone within the veteran's family or the veteran, him or herself, needs to be able to manage a budget. And this is not always something that we see, so it's not for everyone.
So do you think we could grow it?
I do believe that there are pockets where we could grow it, and I do believe, because I've had some personal experience coming from the field, it does go to that local relationship with the area on agency, agency, and that part. We just need to figure out what the barriers are in some of these.
So Representative Brownley and I are going to call a 5-minute recess, but over that recess, I want you to be thinking about that program and the potential for fraud. So 5-minute recess.